Psychoanalysis, transference. In the sessions on technique, about 12 sessions on technique, we have covered this topic of transference. But there was a need felt to consolidate the discussions into one, and here it is. Transference is one of the most important of areas in psychoanalysis, especially in practice. One of my supervisors used to tell me that if you don't know anything in psychoanalysis and you wish to master only one thing, master the area of transference, and you will be able to pull off half of therapy. Transference is a very important area. Unfortunately, not a very well understood area. And more unfortunately, everyone believes they have adequate understanding of the area. So today, we will go deeper into the area of transference and lay out in a horizontal sense the canvas of transference, and later on we can go deeper into each sub area of that canvas. So let's start with laying bare the canvas of transference. The origin and evolution. The concept of transference was discovered by Sigmund Freud. Freud realized that his patients were idealizing him, de-idealizing him, falling in love with him, attributing to him things which had nothing to do with reality. Freud started investigating this attribution of characteristics, qualities, tendencies to him which never belonged to him in the first place and which had no reason in reality to be attributed to him. This allowed Freud to slowly uncover this phenomena of transference, especially of thinking of the therapist as a parent and attributing to him characteristics of the parent and developing towards him feelings which one once had or continues to have towards the parent in the unconscious mind. So this is how the origin of transference happened. And initially, Freud thought this was a resistance to treatment, that this was a kind of diversion which was happening in therapy so that we don't get to the root of the problem. Freud therefore termed transference initially as one of the resistances, and he used to call it transference neurosis. All that was happening as a phenomena of transference, it was referred to as a neurotic phenomena called transference neurosis. Later on, Freud came to realize that the transference is not actually a resistance, not an impediment to healing. Rather, it is a communication from the unconscious and it is at the service of healing. Not only it is in the service of healing, it is a great source in the service of healing. Of all the sources at the service of healing, this is among the greater sources at the service of healing. And therefore, Freud started working with transference. And initially, just as he was trying to overcome transference, now he was searching for transference. He was soliciting transference. So there is a 180-degree change in Freud's position from trying to eliminate transference to searching for transference. And in cases where he could not find transference to work with, because working with transference was giving him great results. So in cases where transference was difficult to find, he would call those situations as situations where there is resistance to transference. So we see a 180-degree shift in Freud, transference as resistance to transference. And Freud felt that this was one of the very deep resistances, the resistance to transfer. And this essentially meant the patient was at some level still not feeling safe and capable of trusting the therapist. So unless the fundamental issue of safety and trust was resolved, these transferences were difficult to find. Now there is a diversion here. If the patient does not feel safe, negative transferences can always happen. However, Freud's situations that Freud was fighting, or rather trying to understand and deal with, were not the situations of negative transference. He was grappling with some situations of difficult to find transference, neither positive nor negative. And these were the situations he labeled as resistance to transference. And two things stood out for him in this situation where transference was not easy to see, not easy to find in the therapy room. So he labeled it as resistance to transference, but under that category, he looked at two specific situations. First, the situation of psychosis. And Freud felt initially that psychotics don't make transference because the repression barrier has been blown open and everything inside is now in the outside, and therefore there's nothing to repress and therefore nothing to transfer, because transference presupposes repression. If there's nothing repressed, there's nothing to create transference out of. The repressed material is the raw material out of which transference is manufactured and then put into action. But in psychosis, Freud initially felt transference does not happen. There is no need because there is nothing repressed. Later on in the work of Melanie Klein, we find, and it was clearly established, that psychotics also make transferences, but they make different types of transferences. I believe in later part of Freud, he himself also had realized, or would have realized, that psychotics also make transferences. But his initial position was that psychosis, you don't find transference in psychosis. Similarly, he felt those with narcissistic personality disorder, they don't make a transference. But just as in case of psychosis, later work of Klein proved conclusively, and now we know by everyday experience that transference is clear in psychosis. Similarly, later on, as we go into Kohut brought about a revolution in understanding of narcissism. And then we understood that narcissistic personalities also make transferences, but they are very different type of transferences. They are what Kohut calls the self-object transferences, which are radically different from ordinary transferences we see. And therefore, in Freud's time, and for a long period after Freud, people believed that narcissistic personality disorder patients, you don't see a transference, especially the most difficult of them. But after Kohut, now we know that transferences are there, but of a particular variety. It brings us to this situation that transferences are of many types and they are always there. It depends on whether we have the knowledge and the skill to identify the transference which is there. And here we are in a situation where it is said, you cannot see what you don't know. So the more we know about the way the mind operates, more different type of transferences we are able to identify and work with. So there is no question of transference not being there in any situation of therapy. Transferences are not only there, they are of multitude of colors and flavors. Transferences come in all colors and flavors. So there is a rainbow of transferences of different nature, different intensity, different purpose, different origin. Transference is a very important element in psychoanalysis, especially in therapy, in working with the clients. And two important elements have come out of the significance of this phenomena of transference. One, the frame of psychoanalysis is the way it is owing to a multitude of reasons. One of the important reasons is that of transference. That the frame of psychoanalysis and the positioning of the therapist as a blank screen has many objectives. One of the prime objectives is to solicit transference. The more blank screen the therapist is and more Puritan way the frame is implemented, the more deeper and purer transference comes on the screen. And one important element to recognize transference is that the therapist has to have himself thoroughly analyzed, because in response to transference, the therapist gives the response, psychological response of countertransference. And the therapist often, not always, but often recognizes transference from countertransference. And when you are doing this, when you are trying to recognize, when you are trying to recognize transference through countertransference, then it is very necessary to be clear what is your material and what is in response to transference. This can be done only if you are thoroughly analyzed and you know yourself. Else, your own material can be passed off as countertransference. And you may start suspecting a transference which is not there in the first place. So two things are very important in one, in soliciting and recognition of transference. To solicit the transference, the strict implementation of the frame and the blank screen idea in therapy, that is very important for soliciting transference. For recognition of transference, there are many ways of recognizing transference. The most explicit way is the patient speaking openly of you as the parent or as somebody else. The patient says that he feels you are like X. So it's a very verbally articulated, clearly said situation of transference. That the patient knows it, you know it. Second is the way the patient behaves with you and he speaks with you without himself knowing about it. That you can make out that he's treating you as an omnipotent parent, as a idealized parent, or as a hated parent. Second situation of making out the transference. And the third situation is of making out the transference from your counter transference. And in this situation, our own analysis is of primary importance. This was about the origin and evolution. Let us now go into the mechanics of it. If we take up the concept of transference, in a generic sense, we are talking about displacement of affect and ideas, primarily affect. In fact, it can also be ideas. Let me just put it here. In everyday life also, we have displacement. So the root of the whole phenomena is that the human mind is such a system where movement of ideas and affect is possible from one subject to another subject. This is the generic necessity as a necessity of an elemental process which enables many things. Once you have this possibility of movement of affect and ideas from one object to another object, it opens up various types of movements. In a generic sense, you can call it displacement. Displacement of ideas and feelings from one object to another. It's a movement. This movement you can call as, you can divide into three parts. One is displacement, second is transference, third is projective identification. So this movement of ideas and affect from one object to another, this movement can take different colors and flavors, and we can divide all these movements into three parts. A generic movement that we call displacement, a specific type of movement we call transference, and yet another specific type of movement we call projective identification. So three broad categories of movement. First, when we take displacement, displacement is seen in everyday life. If you are angry with your boss, you come home and you become angry with somebody else. It's displacement. The movement of affect, anger here is from the boss to somebody at home. Second movement, instance of movement, is what is called phobia. Say a client is afraid of, say, let us say a client is afraid of a particular object. Let us say the object is say a cat. Somebody has a phobia of a cat. Now what has happened is, cat, which is otherwise an innocent object, suddenly becomes for that person an object of phobia, an object of fear. What happens in the unconscious mind is, the anxiety or fear related to object X is displaced onto the cat, and the cat now becomes object of anxiety. An innocent object now becomes a phobic object, because fear of something in the unconscious mind which we don't know is displaced onto this innocent object, which converts the innocent object into a phobic object. So there is displacement in phobia. Similarly, there is displacement in transference. And there is a movement in transference and movement there is a movement of affected ideas. The movement can be categorized into displacement. It can be simple everyday displacement or a phobic displacement. The movement can also be categorized as transference. In transference, what happens is, there is a role attribution. There is a movement of affected ideas from one object to another, but there is a social role attribution of a father, mother, lover, or some role attribution to the person. So it is not only a movement, the movement also involves a particular role. And there is a role attributed to the other, a role attributed to the self. And in association with this role attribution, the movement of affected ideas takes place. Number one. Number two, the feeling of transference happens through our response to that role attribution, that package of role attribution, and the affect and ideas it carries. So we experience the transference through counter transference, which means the transference is put into us, but we don't recognize it directly as it is. We give a response and we actually recognize the response. So experientially speaking, when we detect transference through counter transference, it is only after a response is given that we detect it. If we detect it directly by literal expression or by behavior, that's a different thing altogether. But most transferences are detected by counter transferential elements. And here we don't experience directly what is put into us. We experience the response to it. So that is a critical thing about transference, that one, it's a movement of affected ideas involving role attribution. Two, when we recognize it through counter transference, we don't feel it directly, we feel our response to what is put into us. Third, transference is not particular to therapy, it happens everywhere. In any human interaction, not any, but I would say in most human interactions, transference is at play. So it's a very normal part of human interaction, not necessarily anything pathological. How transference happens, the mechanics are still unknown. Does it happen by audio signals? Does it happen by certain smells? Does it happen below the threshold of our uh, sensory recognition or above it? We don't know. But it does happen, that is for sure. In projective identification, the movement is different. In projective identification, ideas and affect, and mostly affect, is put into the person, the therapist, the host, and the person directly feels it. So if somebody puts irritation into me, I might give a counter transferential reaction of anger. I don't experience the irritation, but I experience that anger in response to that irritation. But if somebody puts in irritation as projective identification, I directly experience that irritation. So here we have a movement where there is no necessity of role attribution. You can put pure affect without any role attribution or role involvement, and it is directly experienced. So in transference, we have role attribution as a very important element in that phenomena. And most of the times when we are making it out through analysis of counter transference, we are not experiencing directly what is put into us. We are experiencing the response to what is put into us. But in projective identification, we directly experience what is put into us. Transference and therapy. How deeply and how pervasively, almost how fanatically, you use transference in therapy. Based upon that, you can divide psychoanalytically oriented therapies into two components: psychodynamic psychotherapy and pure psychoanalytic psychotherapy. So when we use transference partially, we don't work always in transference. We don't believe that everything that happens in the session is in a transferential movement. Then we are practicing psychodynamic psychotherapy. If you are practicing pure psychoanalytic or a pure Kleinian kind of therapy in a very Puritan sense, then we believe everything that happens in session has a transferential component, and you always have to bring yourself in to the analysis. So the supervisory advice always is bring yourself in. And this gives rise to the question, can the patient not say something which is innocent from transference point of view? Is it necessary that all the patient says in therapy has a component of transference into it? Does everything need to be interpreted? Can something not be as it is? And there are different opinions. Personally, I do believe that everything is not essentially transference. There can be things which are as they are, and you don't have to bring yourself in every time. You are not the unconscious object of reference for everything the patient says. So this is how transference is used partially or pervasively in psychoanalytic psychotherapy. Now let us look at how it happens and how it is used in therapy. The transference is so important for healing that by frame and by anonymity of the therapist, we actually solicit transferences. We accelerate the process of transference, we enable it, we support it, we solicit transference. Because through transference, something that is hidden comes up to the surface, and once something is up at the surface, we can talk about it and we can deal about it. We can hope to change it. It's very difficult to change something which is unconscious. So what is unconscious has to be first brought up into the discussion so that change can be instituted, rather incubated. There is also a technique which we cannot go into here, but there is a technique especially practiced by a few Kleinians called collecting transferences, where through certain interventions of technique, transferences of the patient which are spread over many people are slowly collected and put onto the therapist. So therapist becomes more and more of a universal screen. And this is a technique of collecting transferences. The more you can collect, the quicker you can collect, the more you can solve, the quicker you get results. That is the approach. Does transference start with the first session? No. The moment the person decides to call you for the first appointment, transference already is at work. And most of the time, it is the transference of omnipotence. And usually it is a mixture of the good and the bad parent, more of the good parent, and therefore the person is coming to you. But there is an anxiety also. Occasionally, the anxiety of just pure power in front of you. Occasionally, the anxiety of the fact that you are going to explore difficult parts of yourself. And occasionally, it can be anxiety of partly the projection of the bad parent, transference of the bad parent. We forgot to mention projection. Projection also is a type of movement of affect and ideas. In that, the person neither responds. I think we should change it. It will be helpful next time. So when we talk of movement of affect and ideas, we said one is displacement, second is transference, projective identification, and projection. In projection, there is a movement of idea and affect onto somebody, but that person has no idea what is being projected onto him. It is only the person who projects feels the results of it. So unlike in transference, there is no counter transference. Unlike in projective identification, there is no direct experience of what is being projected. So this is the softest of the three. Transference is in between, and the most intense is projective identification. Transference of course happens in therapy, and we interpret it, point it out, request the person to work upon it, and results are there. The question is, just as transference starts even before the therapy begins, the moment the patient starts talking to you about appointment or decides to talk to you about an appointment, does the transference end with therapy when the therapy ends? And the answer is no. Transference does not end with the therapy. It continues even after the therapy ends, and it can continue for years. Similarly, the counter transference in the therapist also does not end with therapy. That can also continue for years. Therefore, patients leave the therapist with feelings to deal with for years, just as the patients themselves carry in themselves feelings towards the therapist for years after the therapy ends. A very important element is, which people don't understand and talk about. They don't talk about because largely they don't understand, is a very important question in the area of transference is this: how pure a transference do you want? And to say 100% pure is a stupid answer to give. It's a very complicated question. How pure a transference do you want? And this is related to how human can you be in the session. How much you will sit on the frame, how much you will continue to be anonymous and the blank screen, and how much you will be human in the session. And that has a very strong relation to how pure a transference you want. If you want 100% pure transference, you will have to deploy the frame and your own anonymity to the textbook definition. The more the frame is loosened, the more self-revelation happens, less and less the pure transference will come into play. And the question is here, there are some important questions. One, if you want a pure transference, can it be managed? Pure transference is not easy to manage. Strict implementation of the frame and anonymity in many cases can lead to unmanageable transferences. It leads to what I call destructive affect mobilization, DAM. And I always say, damned if you damn. It may lead to mobilization of such strong affects, such strong transferences that it cannot be managed, and it can lead to many difficult things in therapy. It can lead to such a positive omnipotence transference that the patient falls in love, or the patient just becomes completely dependent and infatuated with the therapist. And the moment it is broken, it is so heartbreaking and so sadness provoking that the patient may find it difficult to continue with therapy. Or it may lead to such negative transferences, such strong, pure negative transferences, that the being in therapy creates such horror that out of anxiety and unbearable fear, the person doesn't want to come to therapy. So the situation of pure transference can lead to unbearable positive transference, unbearable negative transference, and can be detrimental to therapy. So it is not true that purer the transference, the better. Absolutely false. The real situation is it has to be calibrated patient to patient, situation to situation. Difficulty is once the frame is loosened, there is no way of going back. So we have to be very careful about deciding how pure a transference we want, what intensity of purity of transference can be managed, and more importantly, not more important, but equally importantly, what are you going to do with it? Do you really have the skills and the tools to do something with that transference you evoke? If you cannot do anything with such pure transferences, there is no point of evoking them. And here I'm not referring to the ordinary transferences of anger for the parent or love for the parent or something of very ordinary type of transference. I'm referring to very early life, deep-seated Kleinian or Cohesion kind of transferences. There, this thing comes about that do you really have the skills of using part object transferences if they come, self object transferences if they come, and if you don't have the skills, why evoke them in the first place? Because you will be in a situation where you have evoked a transference, you don't know what you have evoked, and therefore there is no question of doing anything with it. It is just you are putting everything in the hands of fate. So you have to be very clear how pure a transference you want, how pure a transference you can manage, and what are you going to do with it. And this also has to lead to what type of transferences are you equipped to deal with. And here you may need help of a consultant supervisor for a short time, not the general supervisor. Of course, general supervisor is there, but a consultant supervisor to deal specifically with this very deep-seated, difficult to deal with transferences. Early life object transferences, self-object transferences, part object transferences, very early life omnipotent hermaphrodite transferences. So this is where we have to calibrate how pure a transference we want, and correspondingly we can decide how human we wish to be in therapy, how strongly we wish to enforce anonymity and the frame. Let us now look at various types of transferences. The most common type of transferences is the transference of omnipotence. Equally common is parental transferences, transferences of the lover, the enemy. Jung will call the predator transference. So these are very common type of transferences. Transferences can also be divided into two parts, the neurotic type of transferences and the psychotic type of transferences. The parental, the lover, the enemy, they are very neurotic. The part object transferences, the early life, almost hermaphrodite kind of transferences, these can be psychotic transferences. The split open transferences can be psychotic transferences. Transference also depends on the school that you use in two ways. One, based on the school that you are trained in, you can recognize a particular transference. For example, if you are trained in the Freudian school, you can easily recognize the Oedipal transference. But you may not be able to recognize a self-object transference. So unless you get trained in the Cohesion school, you won't understand what is a self-object transference. Or if you don't get trained in the Kleinian school, you can't understand what is a part-object transference. So which transferences you are able to recognize also depends on which schools are you trained in. This is one part of the relationship between the school and the transference, recognition. You can see only what you do. So recognition is first part. Based upon the school you are trained in, you recognize. Second important part is, okay, so first let us go into recognition. If you are trained in Freud, Oedipal transference is easy to recognize. If you are trained in Klein, part object transference, all good, all bad object transference, these are easy to recognize. If you are trained in Winnicott, good mother transference is easy to recognize. Transitional object transferences are easy to recognize. If you are trained in Code, self-object transference, alter ego transference, twinship transference, they are easy to recognize. If you are trained in all of them, you can recognize all of them. You don't have to be an expert in all of them, but expert in one and perspective of many will at least allow you to recognize it, if not to manage it. For which you can go take the help of a consultant supervisor. This is first part, recognition. That you can recognize those transparencies based upon the school you are trained in. Second important element is evoking. Transference also is not school independent. Based upon the language that you use, the focus that you have, and your technique, certain transparencies are evoked. Certain transparencies are privileged over the others, and some may even pass by unrecognized. So, based upon the school and the technique, certain things are evoked and privileged over others. So, it is not true that transparency is independent of the school. You will evoke more and more transparencies which are aligned to the school that you practice. Difficulty will come up when you practice a Freudian school and transparencies are Kleinian or transparencies are cohesion, which means two things. One, either this is a transitional situation which you can manage by having a consultant supervisor, or the patient is being put in the wrong school. If that is so, best is to refer the patient to somebody who is from a school related to which transparencies keep happening for a long time spontaneously. So there is also this whole idea of evoking transference and a patient therapist fit based upon the transparencies the patient makes spontaneously over a long period of time. So transference, the type of transference which happens spontaneously over a long time also has a relationship to the type of school of therapist the patient should be seeing. Take the example of CBT, which does not go into the conceptual area of transference, and yet transferences happen there. And many times those who do CBT don't understand transference, and something difficult happens and the patient leaves. And this is where the ignorance of transference makes you pay a price. But second part is more important when it comes to the evocation. If you keep doing the rational work, but the patient keeps developing over a long period of time, sustained transferences of the Oedipal type or the self-object type, obviously it requires a school change. The patient has to be referred to appropriate school. So even if you don't recognize the phenomena, you don't know it, the phenomena still is at play. Let us look at two important elements: transference and projective identification. Which phenomena is more pervasive in therapy? Quantitatively speaking, projective identification occurs far more frequently than transference. But certain transferences are very enduring. For example, the transference of projection, the transference of the parental transferences on the therapist, they are far more enduring time-wise compared to projective identification. So quantitatively, projective identification occurs far more. Duration-wise, projective identification usually is short-lived compared to transferences, which are relatively speaking long-lived. And some of them go so far as to continue for years even after the therapy is over. The gains that you make by working with projective identification usually are more operational, but the gains that you make with transference work usually are more tactical, at times even strategic. So this is the difference between working with transference and working with projective identification. Both can be equally disturbing to the therapist, both during the session and outside the session. Transference and spirituality. Transference is obviously at great play. It flourishes in spirituality. Most aspirants who go to spirituality have a huge, very intense transference of omnipotence, a search for omnipotence. So there is an intense search for omnipotence and an intense transference of omnipotence onto the deity, onto the guru, or object of reverence based upon what the spiritual practice is. And in packages, spiritual packages like the Mahavidya, transference is used, evoked, solicited in very intense ways so that nothing unconscious, repressed remains after the process is completed. So transference plays out even more intensely, often in far more unregulated way in spirituality compared to a more calibrated, regulated, well-managed situation of psychoanalysis. Thank you. This was about rolling out a horizontal canvas of transference. And some other time we can go into deeper aspects of transference as they happen in each of the schools of psychoanalysis. Thank you.